Now, recent updates on Turner's syndrome focused on following 8 subheadings: diagnosis and genetics, growth disorder and their management, puberty and sex treatment, sex hormone treatment, cardiovascular health, transition from pediatric to adult care, fertility assessment, monitoring and counseling, health surveillance for comorbidities, and neurocognition. Now, diagnosis and genetics. Turner syndrome occurs 1 out of 2,000 to 2,500 females, and most frequent chromosomal change is 45X, around 40 to 50%, and mosaicism with 15%, and mosaicism with Y chromosome materials 10 to 12%. And diagnosis, prenatal diagnosis required ultrasound and fetal echo can suggest, and alpha fetoprotein HCG inhibin A and unconjugated estradiol can be measured. When rapid test is needed prenatally and newborn, other methods like microarray, FISH, or PCR can be done. But postnatal confirmatory test is karyotyping. Now, growth hormone and their management. Growth disorder is common, and growth hormone treatment should start early, because growth failure in Turner start before birth and is rapid during the first year of life, and may be continued until little growth potential remains. Bone age equal or more than 14 years. And previously it was equal or less than 14 years, but recent update is more than 14 years, and or height velocity less than 2 centimeter per year. And higher dose is needed, and maximum dose 68 microgram per kg per day. And very low dose estrogen supplementation in pivotal years, not to routinely added. And puberty and sex hormone treatment, measuring LH, FSH, and AMH at 8 to 9 years and yearly until 11 to 12 years, and timely referral for fertility preservation. Estradiol, transdermal estradiol is best, and oral estradiol second choice. And low dose oxandrolone can modestly slow the progression in response to estrogen treatment, and oxandrolone should be considered in very short girls only until estrogen therapy is started. And initiation of low dose estrogen replacement 11 to 12 years, and increased slowly to adult replacement doses over 2 to 4 years, and incremental value start on an average 6-month interval, and adding cyclic progesterone only when breakthrough bleeding occurs, or on an average 2 to 2 years of unopposed estrogen exposure. And individual with later diagnosis more than 12 years of age who have short stature, combining low dose estradiol simultaneously with growth hormone can be given. And treatment should continue until usual ages of menopause, and then reevaluate for possible continued lower dose after menopause. Usual ages of menopause. Now, cardiovascular health. Common comorbidities of Turner's are bicuspid aortic valve coarctation of aorta, aortic dilatation, and fatal aortic dissection. Monitoring protocol for girls from infancy to 16 years of age by cardiological general examination, cardiovascular examination, transthoracic echo, cardiac MRI, and ECG. If no coarctation of aorta, bicuspid aortic valve, or hypertension, then categorize by Turner syndrome specific Z score. If Z score is equal or less than 3, low risk, and monitoring every 5 yearly. And if coarctation of aorta, bicuspid aortic valve, or hypertension is present, then categorize by Turner syndrome specific Z score, either moderate or severe risk, and monitoring accordingly. After 16 years of age, monitoring done by aortic size index. If index is high, monitoring more frequent. If index is low, then monitoring every 5 to 10 years, according to aortic size index. And main risk of Turner's aortic tearing, so for prevention, earlier therapies is needed. Number 5, update transition from pediatric to adult care. Early adolescence is an ideal to promote development of independent self-care behavior, create awareness of personal health history, and promote health lifestyle. And specific topics should be addressed like estrogen therapy, reproductive issue, and healthcare checklist for adults, lifestyle requirement, and psychosocial assessment. And fertility assessment, monitoring, and counseling. Appropriate disclosure is essential for potential reduced fertility in individual Turners and increased risk of maternal and fetal complications in compared to general population. AMH should be monitored annually if fertility preservation is considered. Controlled ovarian stimulation and oocyte cryopreservation is an option in post-menarche individual of appropriate psychological maturity. And counseling of Turner syndrome girls and parents as early as possible after diagnosis by multidisciplinary approach. Focused on fertility preservation, foster care, adoption, surrogacy, etc. And health surveillance for comorbidities throughout the life. Height, weight, BMI, and blood pressure should monitor at diagnosis and every visit thereafter. Renal ultrasound and assessment of congenital hip dysplasia at diagnosis, and thyroid function, skin, ophthalmologic, and dental examination at diagnosis and then annually. Audiometric examination at diagnosis and 3 to 5 yearly. Celiac disease screening, skeletal assessment by DEXA, 5 to 6 years of age, at pubertal age 12 to 14 years of age, and when discontinuing estrogen or at menopausal age, as usual 50 to 55 years of age. Liver function test, HB, hemoglobin A1C annually after 10 years of age, and vitamin D 2 to 3 yearly after 10 years of age. And lipid profile during transitional phase like 17 to 18 years, then annually. And neurocognition and its implication. Cognitive and psychological challenge associated with Turners include attention deficit or hyperactivity disorder, specific learning disorder, social communication disorder, autism spectrum, and developmental coordination disorder. Thank you everyone for patient sharing.